and welcome to another Piper Pearl. Today's Pearl, we're going to look at something known as a TOTAPS consultation. Now, for those that aren't aware, TOTAPS is traditionally used for musculoskeletal injuries. Musculoskeletal injuries are excessively common as far as presentation goes, and they are the most common presentation that we get in the military. Unfortunately, their prevalence doesn't always equate to the efficiency or effectiveness of their management. So today we're going to go through a general consultation. Now this lesson has the potential to be enormous. So I'm going to cut away a lot of the education detail and recommend areas that require more self-research. Now for those that are in a position to have access to my Moodle or a Dell site, there is a comprehensive study guide that attaches to this lesson that provides a lot more detail than I'll be able to go through today, especially on anatomy, physiology, the specific conditions and the management of those conditions. So it's recommended that you take the time to review that document. You don't have to read it cover to cover by any stretch of the imagination, but it is a handy tool to assist in your study. So moving right along, as I mentioned, it's a method of breaking down an effective consultation to cover off on lots of points. Now, traditionally, it's used in the acute sense by sports trainers, and it's used to denote whether or not an athlete is able to continue gameplay. Okay, so the recommendation is you do a little bit of first aid first as required, because obviously these injuries can be fractures and therefore require just the immediate management. You move into the TOTAPS assessment and then you ascertain whether or not it's bad to refer to clinicians or to allow them to play. So we can do the same thing with our patients, especially if we're in a position where that patient has a particular skill set and they're on a mission where they have to continue. You can do this assessment as evidence of ensuring they can actually achieve the goals. But on top of that, it also can be used as a handy tool for clinical consultation, and it aids in obtaining all the evidence you need to justify a referral, to give good restrictions, and to obviously undertake the immediate management as well. Now, having said that, an assessment of musculoskeletal injuries, particularly through TOTAPS, are really difficult when you're dealing with a real acute injury. So if you have a super acute injury and the person is unable to move at all due to large amounts of gross swelling and pain, then this assessment pretty much is pointless. And all you do is you move into immediate management of that individual, which includes pain relief, referral, and active movement as far as pain persists. Diversity of injuries are huge in this category. There's literally thousands of conditions that you can come across when dealing with musculoskeletal injuries. So the goal of the consultation is not to diagnose exactly what is wrong, especially on first presentation. The idea is to find out what sort of injury the person has obtained in order to put them on to the best management and recovery process they can, with correct education and good referrals that aid in expediting their return to full function. That is the goal. So TOTAPS itself is obviously an acronym, and it stands for talk, observation, touch, active movement, passive movement, skill test, which also can be coupled with special tests when you're trained. So this is broken down to your general consultation, where you have a mixture of subjective data, objective findings, and then you'll need to make an assessment and come up with a treatment plan thereafter. So from here, we're just going to break down each one of these areas and highlight a few things that you can look for in order to optimize the evidence that you obtain for your patient. So when we're dealing with talk, that means the gathering of subjective data. And you can use EPSAN, again, as we have done throughout this entire series, or you can choose pretty much whatever acronym you like to use or method you like to use. But the questions recommended here are very important. So when we're dealing with the event, in this situation, we need to be very detailed and we need to know exactly what happened to cause the injury. if the person knows. Sometimes they wake up and they just have pain, they don't know, but in the event that there's been a catalyst to the injury, we need to know all the details. We need to know when it happened, we need to know what forces were involved, whether they were running, walking, jumping, what surface they were on, the angles in which something rolled or they landed, any extra weight they were carrying, so we can get an idea of how much damage the person may have done, and obviously any other person involved, especially when you're dealing with sport. So the idea is we need to sort of paint a picture of how much force was involved in this injury and how much of that force was transferred directly to the injury as opposed to dissipated across other things. Now, by no stretch do you need to get the calculator out and do in-depth math, but information as described does help paint a picture of certain injury patterns and severity as well. So just get the full detail of what occurred and just make an assessment on there. Ask the patient if they heard something, a crack or a snap, even a pop can be sometimes what the patient hears, and that can be indicative of a fracture or quite a significant ligament/tendon rupture. When we move into past history, we need to know about that particular area. If it's a joint, we need to know if they've had similar injuries in the past. We need to know their current medical health, if they've got any problems. And we also need to know their physical training history. This is particularly important because it generally leads us to information like motivation for recovery and also their general level of fitness prior to the injury. People that have a high level of fitness prior to getting injured, coupled with motivation to recover properly, often will heal better and are more likely to listen to advice than someone who isn't physically active and is not really motivated of getting back into physical activity as well. So sometimes that piece of history can help what sort of education you need to and motivation you need to provide the patient. We also need to know what sort of treatment the person has done themselves to the injury. When we get to treatment, you're going to learn that rice is not the best treatment for musculoskeletal injuries, and quite often it's what's done. Okay, so you need to know what people have done at the start, what medications they've been taking, all this sort of stuff in order to provide proper education, which I'll go through, and obviously sometimes counteract some damage that could have already been done, unfortunately. Moving on to our subjective questioning, because the pain is the main complaint, we need to do a good pain profile. So PQRST is a handy one to use, and we need to know what makes this pain worse and what makes it better. If there's pain only on weight bearing, then it's generally denoted around a joint. If there's pain all the time or associated with contraction, then you're dealing with a muscle. If a person has relief from pain when they put pressure on it versus when they're resting, all this information can help denote what sort of structure we are dealing with. The quality of pain tells us a lot. We have things like sharp pain is the most common description of pain for musculoskeletal injuries, and it denotes nociceptive pain, often associated with inflammatory. So they'll explain things like sharp throbbing or aching, and it's also well localized. So that's the most common form of pain, and it's usually felt by the peripheral pain receptors. When you move into dull pain, that's more characteristic of visceral pain, okay, where you have this dull, aching, or colicky, or even cramping pain. And when you move into someone explaining pins and needles, then you're moving away from nociceptive and you're moving into neuropathic pain, where a person can explain pins and needles, burning, shooting sometimes, or even electrical-like pain. That's more indicative to neuropathic pain. As I mentioned, if the person's able to pinpoint where it is, then it's more likely nociceptive and inflammatory-based pain. But if they can denote the depth of it, then you're dealing with the difference between bony structures versus superficial structures like skin, subcutaneous tissue, or even muscle as well. Severity gives us an indication of how much it affects a person's life and how much pain relief we're going to have to give. Time is twofold. We want to know how long they've had the pain, so how acute the injury is, because that tells us how long they're going to be in the inflammatory phase versus proliferation phase, which is not always an absolute, because if someone re-injures themselves, then inflammatory can keep going on that little bit longer than the traditional 3 days. But we also want to know if it's a constant pain or if it's intermittent, or if it's only associated with certain stimulus like moving, putting the joint in a certain angle. All this sort of information really helps us understand what is happening in the person's body. Allergies is good to know because medications are quite common with musculoskeletal pain, so we really need to know that. As far as medication goes, we really need to know what they're on. Okay, we need to know if they're prolific users of COX inhibitors like ibuprofen or other non-steroidal anti-inflammatories. Any natural therapies they may have tried, whether it's Tiger Balm, St. John's wort, whatever it is, we need to know because there's interactions associated with it. Another consideration that often gets overlooked is the prolific use of creams. Okay, so not just the natural therapy creams, but also things like diclofenac cream. When people take that and they couple it with ibuprofen, they are taking 2 COX inhibitors, which just increases the probability of side effects like bruising. So you need to know what's going on in order to add to the education when you move to the treatment. When we finish with our subjective collection, we move on to our objective findings, and we start with observation. And we have a look for any gross abnormalities. And they can be quite easy to see when you're dealing with things like dislocations. Sometimes you won't actually notice too much, and other times you'll have things like gross swelling. Have a note of the skin color. Obviously bruising is nice and easy, but you can also have slight discoloration that denotes an increase in pressure or effusion in that area, which has changed the color of the skin due to reduction in circulation. Use the other part of the body in order to see what is normal for that person and get an idea of whether or not asymmetry is there. Observations mostly for you just to denote all the big things that can be seen for investigation and things to take into account as you move through your other objective findings. When you move to touch, which is also known as palpate, you need to be gentle at the start and only go firm if the person doesn't feel pain initially. If the person feels pain on light touch, then there is no reason whatsoever to go any firmer than that. That is pretty much it. You can always palpate the good side to compare it to the bad for the same reasons we did for observation. You can ask about points of pain, but a good trick is to look at someone's face, because it doesn't matter how stoic the individual is, it's very difficult to hide pain. If you find the right spot, you'll generally see it on their face, even if they deny it. As you're palpating the area, you're feeling for things like effusion, like fluid shifting, pitting edema, feeling for spasms underneath the skin. Really fine muscles can spasm, denoting a pathological problem. Crepitations, like joints cracking, that sort of thing, and any guarding, so any part of the body that has contracted, almost like a corky that you'll feel, that denotes the body is guarding it, which is indicative of an injury underneath. You can also use this point to palpate certain areas associated with Ottawa rules in order to see if there's associated pain that denotes the need for an X-ray. After palpation, we move into manipulation. And before we do that, we need to understand certain rules, and we also have to have a good understanding of the terminology and the anatomy. So a general rule when you're dealing with manipulating, particularly joints after injury, is you only manipulate as much as is needed and no more. So to the point of pain, and then you stop. And that's what your notes dictate, is patient felt pain at this point, and then that's it. You need to be slow but firm when you're doing your passive movements. So when you're supporting and you're doing the passive movements, there's no jolting, there's no quick. It is slow, but it is a firm movement, and you stop at the point of pain. It really helps if you know your terminology, like your planes and your movements, flexion, extensions, rotations, all these sorts of things, so you can use the correct terminology. And you really need to know what is a normal range of movements of the joint. If you don't know the normal range of movement of a joint and you don't know how to manipulate that joint in order to assess it, then don't. Don't do it initially. You could cause further damage. Go back, refresh your training, get further training if you need it, and hand over in your notes that basically you couldn't assess that particular joint through its manipulation. Okay? You're better off being honest with yourself and the patient as opposed to putting the patient through something which is pretty much going to end up being pointless because it probably wasn't done correctly. When we're dealing with active and passive movements, we first of all let the patient do active movements, and this is what's known as dynamic flexibility. So this is how much the person can move as a result of muscle contraction. So it's not the best indication of whether or not there's stiffness because there's really little resistance in it. The person's just moving their own joints. Now, if the person's unable to do the full range of motion, then it can mean that there's a musculoskeletal problem or there can be an obstruction in the joint. So really from active movement, you don't know much, but you take the information and the angles that the person can move in the range of movement from active, and then you move it to passive. Now, passive, the person has to be completely relaxed, and this tests static flexibility. So it's really testing how far the joint can move to the real end point of range of motion. Okay, so generally speaking, all joints have a little bit extra to give when you stretch the ligaments that you can't do under contraction alone. So when someone is going through a static stretch, then they can generally get further movement as associated with just contracting themselves. Now, if the information says that they have reduction in movement on active, but they have more movement on passive, then that's more indicative of a musculoskeletal problem, so a problem with the contraction mechanics as opposed to the joint. If they're equal, then generally it means that there can be some sort of obstruction or inflammation or mass within the joint that is stopping that particular movement. So it just can paint a full picture. When we finish with active and passive movement of the actual area, we move on to our skills test. Now, skills test is normally denoted where we get the athlete to go through a series of skills to see if they can actually perform on the field. Now, obviously, if we're supporting a sporting event, then we can do exactly the same. But if we're on a specific mission and we need an individual to be able to perform certain roles in order to not become a liability, then you can also do specific tests to see if they're okay to continue. See whether or not you need to arrange for evacuation or removing this person from the environment in order to keep them and the rest of the team safe because they're unable to perform certain functions. So depending on why you're doing this consultation, this point can just be done as a skills test to see if they can continue. If you're doing it as a consultation where there isn't a specific mission in mind that needs to be continued, then skills test can be swapped for special tests. And this is where we can go through strength tests. Strength tests realistically are only done if you believe that there's actually a problem with the neural pathways and strength. If someone has an injury to the hand, which means they can no longer make a fist, then doing a strength test on the hand doesn't actually mean much. It just actually means that they can't physically move, which you've already ascertained through active movement, so therefore there's no associated strength with it. Now, you can test the strength of joints, but if it causes too much pain, then don't do it. Normally, it's whether or not a person can move against gravity initially, and then against resistance, and then whether or not they have normal function. So there's a scale between 0 and 5 that can generally denote how much strength the person has lost. Now, this particular grading is really subjective. Okay, so when you read it and you hand over, take it as a grain of salt, and the people will probably redo the tests, and it can change quite rapidly depending on how the test was performed and the associated inflammation. From strength test, you can move on to reflex and sensory test. Now, if you don't know how to test reflexes, then don't. No real reason in the acute sense, but you can test sensations associated with pressure, pain, and vibration. As you can use a pen where you use the blunt part, and then you use the pointy part, and then you get your good old tuning fork for vibrations. And it's graded as if it's 0, then it's normal. They can feel the difference between pain, pressure, and vibration, no problems at all. If it's decreased, so they can only feel some but not the others, then it's a 1. They can't feel any of them, then it's an absent as well. Another really important special test is looking at somebody's gait. When you look at somebody's gait, it can tell you a lot about how much the injury is actually affecting the person's life. Even if it's associated with the lower limbs, sometimes a back injury can affect the gait as well. And you can also look at the stupor, the way that they position their upper body, to denote whether there's guarding associated with the injury that they have. So everybody should have their gait witnessed, and whilst you'll probably do it right at the start when you meet them, it generally fits into the special test realm. So if you need to put them through it again, just ask them to walk if you didn't pay attention the first time. From there, we have a whole range of special manipulation tests. Now, if you have access to the ADL platform, there's a list of a series of different tests that can be done for each of the joints that you can go through, look up, and practice. There's not much point in me explaining it over a video like this because it will just be lost. Okay, there's a lot of different tests for a lot of different reasons that you can get proficient with to add to your arsenal, but most of the time these are performed post-inflammatory phase. So once they move into proliferation, and it's generally used to denote some thought of injury or pathology that's happening within the joint. So again, if you don't know, don't do. When you have all your data, then you move on to your assessment. Now you need to obviously know why you're doing this assessment. If it's a functional assessment to see if a person can continue, then that's what it is. The recommendations is they continue, or you refer them on for a more robust consultation. If it's a consultation, then you can make some decisions. We need to know whether or not it's an emergent situation, so whether or not it fits into the realms of a fracture. So you can use things like the Ottawa knee rules and the Ottawa ankle rules, the Ottawa foot rules, in order to palpate different areas of bones, coupled with their inability to weight bear and sometimes move joints, to denote whether or not they need an X-ray of a fracture. If they believe it's a fracture and it doesn't fit into one of these particular joints that you can use, then you can use the good old tuning fork again, 512 hertz. You can flick the tuning fork, rub it over the top of the area, and even press it onto the bone beside the fracture where you believe it is, and that will cause the vibrations to go through bone conduction. And if it increases the pain that the patient feels, then it is generally indicative of a fracture. Okay, so that can be a test that you can do. From there, if it's not a fracture, you look into whether or not you think it's a soft tissue injury and whether that soft tissue injury involves the joint or not. If it does involve the joint, then it sort of means you need more specific treatment than if it doesn't involve the joint. If it's just a muscle based, then general management from the patient and time can actually help, as opposed to getting specific recovery exercises from physio. From there, part of the assessment has to be, how much does it affect them? How much does it affect the person's goals? What does the person want to return to do? Does it interfere with their work, their personal life? All these sorts of information needs to be assessed, because that will give us everything we need to know when we move in to treatment. Everybody with a musculoskeletal injury needs education. Unfortunately, the meta-analysis out there have showed that about 20% of patients will actually receive information. In particular, when someone has lower back pain, only 20% of them will receive the required information about recovery and about the overuse of over-the-counter medication. So those two alone are absolute paramount. When you're moving into treatment, the patient needs to be educated away from certain treatments, because certain treatments like ice have been part of a patient's and the world's bread and butter for so many years that it's actually ingrained in people, ingrained in sporting events, and people will really do it every single time unless you educate them out of it. So I'm going to do a separate lesson on why ice should never be used in musculoskeletal injury, why rest is also a bad idea, and why compression and elevation also have weak evidence and offer better evidence-based treatment associated with that. So have a look out for that one. This lesson will just be too long if I go into too much detail now. So always educate them on the management and non-pharmaceutical methods, which mostly involves active recovery. Active recovery is the goal, and that can be coupled with special exercises given by the physio. Okay? But that is the main treatment. When you're moving into the use of analgesics, there's a scale. You want the person only to use analgesics if the pain is stopping them moving. If they can move and they can sort of work and soldier through the pain, if you will, then it's best for them not to take analgesia. And if they have to, paracetamol is best. And then short-term use of non-steroidal anti-inflammatories. Now, I know paracetamol is one, but I'm talking about the COX inhibitors as opposed to the central prostaglandin one. Okay, quite different. So if someone is going to take ibuprofen, naloxone, all those other ones that are associated with the COX inhibitory, then it will not improve the patient's recovery. And there's a bit of evidence out there that suggests that it will actually retard the actual recovery. So use it short term and only use one, either oral or topical. If they want to use Voltaren gel, then they don't take ibuprofen. From there, if the patient is in significant amount of pain, then really it needs to come with a referral, because from there you'll move into weak opioids, and then you'll move into adjuvant analgesics, and then only after all those things coupled with recovery fail to manage the pain, do you move into your strong opioids. Okay, but it's actually quite a large, complicated and chronic management plan that really needs to be done by specialists. Okay, so once we get past the point of educating on non-steroidal anti-inflammatory use, really it moves on to a referral, because then it moves into the realms of complex management, where the patient still needs active recovery, physio, and also further management of their pain. From there, we give restrictions. We keep the person's goals in mind. Okay, if someone is highly motivated and they're going to get back into whatever because they have a competition or they have something coming up, you're really not going to stop them. So you're better off educating them around safe activities and safe recovery. So the information is out that if someone has an injury to a particular area, then they're actually better off training that area in the absence of pain or to the point of pain than they are from training, say, any other area. And this is believed to be the case associated with increasing blood flow and increasing that lymphatic draining, which helps remove a lot of the damaged areas and also helps excite certain growth factors like insulin growth factors, which or actively repairs muscles. Okay, so active recovery and using the area in the absence of pain is the best recommendation. So don't shatter someone's goals because they're probably going to ignore it anyway. Work with them and tell them they can rest, but keeping someone moving and keeping someone useful is often the best treatment for musculoskeletal injuries. And if they need to rest, make it intermittent resting as opposed to entire bed rest for days and days on end. Be very specific with your restrictions. Saying things like no load bearing is not specific. Okay, so tell them the risk associated with heavy load bearing and recommend that they can do minor ones to build up to it. Consider the long-term recovery options and whether or not the restrictions are going to actually interfere with their recovery. When you move to referral, early referral to physio and specialists can offer early, even one-off advice on exercise that the person can use, things like resistance bands, in order to aid in that active recovery. Always refer if you think they need imagery, and refer if you feel you have a chronic or complicated pain profile that the person needs proper management for. Okay, that brings us to the end of TOTAPS consultation. As I mentioned, there's a lot to go into and there's a lot of emphasis on yourself doing personal study from here to get better understanding of joints, injuries, injury profiles, all that sort of good stuff that can aid in understanding the findings that you'll get from consultations like this. It's a very common presentation. You will see it if you haven't seen it already. So it's really in your best interest to become very familiar with proper management of these conditions, because only through proper management of these conditions will patients break out of the cycle of chronic injury patterns, and they'll be able to return to full function and provide optimal capability. But until next time, take care.